I'm Gretchen Case. I will use excellent posture so that my hair doesn't touch the microphone ever. I'm from University of Utah. I met some of you last month when I for the Humanities thing. I'm at the School of Medicine. I'm the chief of the Medical Ethics and Humanities program. And my background is in history, communication, cultural studies, and performance studies. I have a degree in all of those, which ends up being useful because what I'm asked to do at the University of Utah is we have a much smaller group than you guys do here, so I have to reach out to a lot of different people and make lots of connections to be able to offer our medical students everything. So I'm a kind of connector more than anything, but my true passions are in performance studies and history and literature education. So that's all that I do. And then Sandy asked me to talk on performance. This is really helpful.
Yeah, I'm gonna try to.
Thank you. I can also use a stick mic for a little while if that's helpful. But she asked me to speak from a performance studies perspective about rural health. And art is always technology. About rural health from a performance studies perspective. One of the projects I've been working on for more than 10 years is with a friend of mine who I've known since high school, who is she has been a CMO and a provider. She's a geriatrician internist in Western North Carolina, and she's in a very rural, remote part of North Carolina. And we've been working together, kind of on the side of our jobs for years, trying to make sense of her experience there. And one of the things we did, starting all those years ago, was we started interviewing all the providers in her county and the next county over about the kinds of things that they were facing, the challenges they were facing, what it meant to be a provider in a really, really rural, remote, underserved, isolated area. And because everybody in town knew what we were doing, this interview, which is with a patient, not a provider, came out of that because this person, whose name is Isla, and she's okay being identified. I've just given her initials and in the paper just because I don't know how far it goes, but both of them are okay being identified. But she said, I have something for your project. So she offered this interview up to us. So that's kind of where this all started. So I'm happy to talk about rural healthcare, thinking about it.
All right. So does anybody have questions on that long email that went through the approach and the key points of the approach and the goals for teaching medical students? And also, we're going to switch it up a little bit from now on according to feedback that the experts are going to present as though they're modeling how they would teach to medical students. You are not supposed to pretend to be a medical student, but so the discussion can be a little more sophisticated. But yeah, the feedback was that was very confusing. Like people didn't know what the audience was. So that is the direction that I've given to the experts. And then the other thing is just as much as people want to jump in and start discussion, I'd like for people to sort of let the expert unfold their portrait the way that they've sort of planned, so we make sure to go through the plan that the expert has set out, and that we know that there's enough time to have to discuss the portrait, but then also to workshop it more and make changes. Okay, so that's how we're sort of dividing it. So Gretchen will teach the portrait, and then we'll take a break, and then you know what? You should see Gretchen, not me. And then we'll sort of workshop on how to, if any revisions need to be made, or if there are any additional feedback to finalize the portrait. I think, yeah, Gretchen's done a lot of revision, and actually you didn't really need that much revision from the frontiers, but has made some changes according to feedback, and so I think this portrait is further along than others. So with that, does anybody have any questions? And then also about how you're getting paid? Yes, no. So it's through faculty development funds. You read this, yes? Or do I need to read it? Okay, I won't waste any more time, and I will.
Is that We don't know.
Okay.
So it is us that's working.
Okay.
9 years.
Is that okay? Or do you want me to hold them for you? You don't have to do that. Okay. All right. So that's it for me. I will give this to Gretchen.
Okay, I'll treat this like a seminar, but I will not talk down to you and pretend you are first year medical students. I would always, actually, even if you said teaching first year medical students, you're going to have a range of people in the room, right? So there is no real like first year medical student. There's always some ringer who's like to the sociology undergrad or something, right? So we'll just go with what we have here. I will say this is probably not something I would teach on the first day or the first time I met a group. So since some of us have met each other before, that's great. But I will tell you generally, like what you would see from me as a teacher, and you're all going to have different styles, is that I like lots of feedback, lots of talking. So even though we're not going to talk in the meta way about how to teach this, as you have questions come up about the work itself, that's the kind of thing I encourage. And I often like change direction as Sandy knows in the middle of something if I feel like it's going better another way. And I would encourage you guys to do that as well and take the material and make it work for you as you want. So as we go along, if anything's confusing or you really would need to ask a question, that's great. I am not the kind of teacher who's like, wait, no questions till the end. I actually prefer to take them as I go, and you would know that if you went out with me for. I'd probably do this like mid-semester or late semester once I had like the vibe for the class and the buy-in and all that. Like this is pretty complex to do like one-off right on the first day. So one thing, and this is out of the last time I presented this, because I'd like to start with an activity. So what I'd like to do is everybody take a piece of paper and a pencil. It sounds like a pop quiz, and it is not. And I am assuming that you all had a chance to read the narrative from IP, right? ILA. And what I would like you to do is draw that emergency room as you imagine it. Okay? So, and you can take, that could be, drawing skill does not matter. We're not interested in skill. But like, you have a picture in your head, right, from reading that of what, and for those folks on Zoom, if you could just like sketch it out for yourself, what do you imagine that looking like? Maybe it's an overhead view, maybe it's walking into the room, maybe you only see her space. But just take about 2 minutes and just sketch out, like, in your head, what that space is to you, because you had to visualize it. It didn't give you any kind of illustration. Does anybody need pencils still?
I need paper. I don't think I can slide it all the way.
Okay, and continue drawing while we're talking. When the technology is available, this is a great thing to do on a document camera or an overhead projector, where you can put it on the screen and everybody can see everybody else's, and it's great to kind of move through them. We're a small enough group that I might ask some of you to hold yours up. And I'm interested, where did you start drawing? Anybody can let me know. Where did you start? When you put your pencil down and you started drawing something, where did you start?
Isla.
What's that?
Isla.
Isla. You started with Isla. Okay. You started drawing her. Okay. Kara, you as well.
I just started, with her space. And
Okay.
the curtain.
And the curtain. Sorry.
Oh, sorry.
Just we want you on the record.
Okay. I drew her. Girl. And the curtain.
Anybody else?
That's what I did as well. I drew it through the emergency room from the perspective of Ida, so I situated her in the space room.
Why don't you just pass it to Anna Maria, and we'll just go around the room, and anyone who wants to talk can.
So I did not do it for that. She's kind of in it, but I did like a top-down view, and then I started with the center where the doctor was, and I drew a telephone.
And you drew a telephone, right? Nice.
Yeah.
I actually drew it as she was going in, so I tried to kind of recreate, like I started with the box and then tried to, kind of from her movement through this.
Yeah, so I drew a floor plan, sort of starting with what I imagined, how I would imagine her situated within the space. The visual encounter that stuck with me was her watching the physician at the station reading the charts. So that was actually the first sort of visual angle that I thought about. And I built it along that, making sure that it was sort of imagining her entrance and going past all of these rooms, people with the neck braces. So along the line of patient carols, and then thinking about the triage area, and then thinking about where the ambulance bay would be, given somebody who's coming in full code. A lot of this sort of derived from also my knowledge of emergency rooms, not from the narrative, but sort of in dialogue together.
Matthew, right? And that's you just verbalize what I'm getting at here, which is that like you all are choosing something that seems like familiar, or it's based on your experience, where you have some kind of bias or connection to where you started.
Yeah, I started from her perspective, and then instead of thought more about how she was kind of seeing everything around her, so retrospective her being everything, and then across from it, the entrance when her coming through, and after I was thinking, I took two most focuses with how she was seeing other folks in the room, how she could see people coming in through the
I did a lot what Matthew did, and do a floor plan, drawing a lot on my knowledge of art, like chronologically based on the people. So I started with the reception, triage in the waiting room, and through her, going past the other rooms, and the whalers in opposite corners of the. They were running back and forth, and I just mapped out that way, and also made the. That was the phone pretty good. Yeah.
I'm gonna pass it to you and Shay, and make sure. Forgot about it.
I started with Isla, and then drew according to her perspective. But the second room I drew was the doctor in the patient that died. I don't know, that part of the story really stood out.
I didn't actually quite get to drawing, but when I was reading this, I had read the teaching guide ahead of time, so I knew this was going to happen. And despite that, I couldn't get it out of my head. The pictures of the I have, which is all from teaching codes. I don't actually did one in my life. Like, and also just picturing all of this happening in these are that I've seen on my character.
Which is important too, and that's part of your experience, whether it's accurate or helpful or anything. It's part of your experience, right? Right, Laura, did you want to add?
The one thing I wanted to add is that when these folks said they drew Isla, I was thinking I drew my room, which is an interesting dynamic of the way that this interview played out. That for me, I was like, I put myself in her shoes. Like, I was thinking of myself as her. And so the only, mine is a very crude drawing, but the one piece that was very important to me was being able to see across to another room. That was the one that wanted me to be able to see into another patient room. Everything else sort of faded and wasn't very well drawn, but that was big.
And then folks on Zoom.
I actually started with the entrance and then drew the doctor's station and then drew her room and the other patient rooms. I did find myself, though, as I was drawing, imagining one of the critical care hospitals where I work and drawing from that experience as I was trying to recreate her scene.
So you were starting with her narrative, but you had to put it in something that you understood.
Exactly, yep.
And Elsa?
Hi, I drew about a patient staring what God, the one that was transfixed, watching what was going on, kind of hoping, knowing that, hopeful at the same time, knowing that it was not going to end well. It's kind of that perspective of just like, I'm detached, but at the same time, I'm seeing everything and being part of it. That really stuck to my mind as I recently had an episode that was very similar to that. So I could see, all the commotion of the people doing, the CPR and trying to resuscitate that patient. And there's always one person who's just standing, not saying anything. And it could be family member, it could be anybody from the team, but someone who just hopeful that things turns out okay, but it's not. But we all know that most of the time it's not going to end well. So that's the part that really portray, and I try to portray on my drawing.
Thank you. So all of you were really thoughtful in what you talked about because you see what you drew, but you also gave us a sense of why you drew it. So we heard from some people, I started at the entrance, I started at the beginning, I started where she enters, or I started in my room because I've taken on her perspective. Or I started with the thing that seemed most important, the desk or the phone, or I took an overhead view, or I took a view from her. So those are all things to think about because you are taking a perspective. You are never an objective observer, and you probably know that. And part of that being subjective is that you are taking some kind of perspective. You are starting somewhere when you retell the story, right? So this is Isla telling her story, but you all, in retelling it, will have a perspective. And it's sometimes so subtle that you forget to kind of interrogate that in yourself, that really what caught your attention was the phone, or what caught your attention was the people in the other room, or what caught your attention was the entrance into the emergency room, all of which could be equally important. So thinking about when you tell someone's story, you're always taking. The other thing you all talked about is your experience, right? So several of you commented on, I did this because I've been in a critical care hospital. I did this because I've never been in an ER, but I have to imagine it from TV. So remember that those kinds of things affect the way you tell stories as well. And that even if two people have the same training and the same, what seems to be the same experience, they're going to process that differently. So even if you have a team of students or a team of providers who've gone in on the same case in the same room, on the same patient, they're going to have a different experience of that. And again, they may all be equally important, but remembering that they're not interchangeable. Because you're called on as providers again and again to retell stories, you have to keep thinking about who you are as the storyteller. So one more thing I'd like you to do with the drawing is, without thinking about it too much, thinking of who you are, just who you are, provider, possible patient, possible family members, stick yourself in the drawing. Where would you be? So where did you put yourself? so Laura gets to start.
I think my answer is clear. I was already in the drawing because I was in the room. So I had the easiest response, and I just stuck myself in the bed.
Okay.
I think a patient bed, or often I tend to be an observer on the side of the room, so I was imagining them there vaguely with someone on the side.
I'm the patient in the area in the curtains next to Ida.
And you can pass if you don't want to.
I put myself as the nurse.
Are we able to? Yeah.
Sure.
I mean, I just assumed I was
Yeah.
looking kind of through her eyes.
Yeah. And that's important. That like just for what you said, it's what what do you bring into the story? Are you thinking I would be this person, or are you thinking I'm taking on Isla's perspective of the story? Both are important.
So I sort of imagine myself, most of the time I've spent in ERs, I've either been a trainee or a consultant where I'm not really part of what's going on. So I sort of imagine myself kind of sort of at the end of the sort of workstation, at the opposite end of the ER, where I could sort of see Isla, but also see everything else that was going on, sort of in the way, but not really. It's sort of very much as an observer.
It's interesting because I didn't imagine myself as Isla, but definitely another patient. So I'm still sort of stuck with my own experience. But as everybody was talking about what they drew, it also struck me that I left walls unfinished in the drawing. Like, I couldn't imagine what wasn't narrated. So there's something sort of interesting about, like, I can imagine not as Isla, but that there were things happening that I didn't know too, and that I think had something to do with me not where I placed myself in space too.
So I drew myself with the center in this position bay. But I wasn't quite sure if I should be sitting at the chair with the telephone or off to the side. So I kind of put myself like next to the chair. I don't know. Like I didn't want to assume that identity of like the on-call position.
I think we could bring our psychiatrist on this.
Right.
I think it's probably just what you said, that
Like,
you're
that's
like,
probably where
what would my role be? That sounds like a really hard one, but I don't want to be totally out of it. I'm committed to the story. So there's some ambiguity that I think is important.
I think ambiguity is what I felt, because when I drew it, I felt like I was Isla. When you asked the question, I felt like I was a doctor, and I was with a patient that was part of your team working on it.
I put myself where Isla was, but I drew little punches. I guess it was. I guess I'm not her. I'm me. Her. We melded.
I will tell them. And then folks on Zoom again. So Elsa and Elizabeth? No, Erica, sorry.
So I drew myself being the observer, but I also was seeing myself the one who went back to the patient. I like nothing happened, in just kind of like keeping that face, that a lot of commotion going inside me, but at the same time, kind of just pretending like nothing happened, and I had to put up a mask and a face to keep going.
Erica?
I put myself in an observer role as well, watching what was happening and analyzing it.
So all of these are worth thinking about. That again, some of you put yourself. It's about perspective. Where do you see yourself entering this story? And Christy, your comment was important about. Well, at first I was a patient, but then I was a doctor. So you as medical providers also sometimes are patients, right? And then those of us in the room who are not medical providers often are in a medical setting, kind of lurking about, right? Like doing something. So we have this dual role that's important to keep thinking about, because again, how are you reading the story? How are you looking at it? One of those identities might take over more than the other, depending on why you're there. If you're in the ER working, you're going to have one identity probably taking over. If you're there as an observer, something else, if you're the patient or family member, something else. So just keeping in mind that like even a familiar space can become unfamiliar or vice versa, depending on which role you play. So this leads us this exercise, I hope, to thinking about why we're talking about this group performance study. And to give you a gloss on performance studies, for those of you who don't know it, and Carrie can correct me when I say anything wrong, she does know it. The idea behind performance studies is that humans perform, and perform means to make something happen. It doesn't mean to fake. But we often think about it as acting, right? So if you say someone is performing, you often think they act. But like on the way in here, I passed something that said clinical performance, right? And you guys are often rated on your performance, and that means how well you do something, how well you make something happen. So what performance studies does, it looks at all of human behavior, human doing things, and on one end, you have humans acting. So humans on stage, right? And we're saying, I'm acting. I'm going to play Ophelia, right? And I'm going to do that on stage. We all agree. You're the audience. I'm the actor. I'm doing this. On the other end of the spectrum is what we're doing right now. She just named me an expert. I'm an expert. I'm going to be an expert, and I am performing the way I think experts should perform, right? Which means paying attention to you guys, speaking clearly, being prepared, all this kind of stuff. There are all these everyday roles that we take on, that we perform, that are not on stage, but they still have an audience. They have costumes. They have ideas about scripts, about what you're supposed to say. And I called it a spectrum because along the way are things that are more and more and more formally performed. So like if you participate in a religious ritual, if you participate in a sports ritual, something like that, there are things where people say, now you say this, now you wear this, right? And it gets closer and closer to that on-stage performance. As you go closer and closer to everyday performance, there's less of now you will do this and more of you looking around and going, that's how you do it, right? And that's part of what I wrote about in that article on the hidden curriculum, which is there's a lot of like, oh, I see. That's how you're wearing your stethoscope. Oh, I see. That's what you're doing with this, right? So performance as a way of kind of like understanding the world and being in the world. So what I had you draw is kind of like what you would do for a formal performance if you're planning on playing, right? What is this space going to look like? Or you might do it for a movie or something too. And you might even build a maquette, right? Like a thing where you make the fake stage. To think about like, how is this going to work out? So that's one reason I wanted you to think about this, is that she calls it a show, and I want you to like, just for now, like accept it as she's watching a show. But her telling is a show to us as well. She, as the storyteller, is telling it from a particular perspective. And storytelling is a very well accepted form of performance, right? And again, sometimes you have people who are like, I'm a professional storyteller. I will come to your party or your festival and I will tell you myths or legends or folklore tales. And then you have, Uncle Bob who's like, let me tell you about, the Korean War. Or you'll have like your chatty neighbor who's like, let me tell you about the lady down the street. They are performing for you, right? They are storytellers in the same way. So anytime someone tells you a story, they are performing. So patients who are giving you a story are performing that story. What do you think some of the things are that might affect the way they tell you a story? And folks on screen, if you just wave at me if you want to jump in, because I don't want to lose you. But I would like to know, like, what do you think affects the way that a patient might tell a story to a provider?
Okay. One thing might be time. I know when I go and say, how much time do I have? How condensed it has to be. I try to figure out what are the high points they need to know.
Yeah, so you might even know how long they have. You might know it's a 13-minute appointment or a 15-minute appointment, and you have 2 minutes. Okay.
So, I don't do this anymore, but I think a lot of patients will say that they are taking their medicine when they're not, or that they're doing all their treatments or whatever they're supposed to be doing to look good to the physician, and then the physician makes their treatment plan according to what they said, but it's not usually, sometimes not based on reality.
And this is a role that is named in medicine often as the compliant or non-compliant patient. the good or the difficult patient right there. And people who are patients can pick up on that. Like, I don't want to make trouble. I don't want to take too long. I'm going to say what I think they want you to say. So sometimes it is labeled and sometimes it is picked up on. And Maria wants to
So I'm primarily a primary care physician, so I hear performances all the time, every day, multiple times a day. And one thing that I, when you first asked the question, thought was anxiety. And so I have a pretty wide variety of patients. So some patients that are very knowledgeable about their own medical condition and have good language skills and speak English as a first language, and they can tell me their story in 2 minutes. But I have other patients that it's their first time in a position in 5 years, and they're super anxious. They think something's going wrong in their body. They can't describe it. They don't have the words for it, and they're just anxious. And so I have patients, some that just kind of they rattle off their 2 minutes because they have it prepared and they're ready. And they know that's like kind of what I'm looking for. And then I have some patients just kind of sit in like therapy, and I have to like do my performance of like what brings you in today, what can I help you with, what kind of stuff is going on in your life, you know. So that was the one thing that I thought about that can be dramatically different from one room to the next room.
I'm glad you brought up your performance in that too, because I think the doctor's performance is really key there too. When I was thinking about my performance as a patient, sometimes the thing that has been bugging me the most recently at doctors is the sensitive patient, sensitive question part of the interaction, which I think gets very performative a lot of times for a lot of different reasons. And what they do to me a lot, what doctors do to me a lot is they say, no tobacco, right? No drugs, right? Which makes me have to say, well, yeah, actually. I mean, I don't actually. I'm say that in this room. But I sometimes just want to be like, yeah, I do all of them. I do everything. Stop pigeonholing me. Like, it really bugs me. And so then I get a little, so my performance gets a little bit different and responds really weirdly to that. And so it's like a performance on their part, I think, partly because I think doctors often want to put me into the position of, like, I know you, you're good, you're great, you know, and I don't know what it is exactly, but it has become this very, like, it's a script that keeps happening over and over and over again, that then I get, like, I want to do the opposite of the script.
So you brought up, can I just follow on that for a minute? So you brought up the idea of the script, and that's something that I write about and I really care about because, one, scripts are often misunderstood as like the thing you do. And if you think about how actors work, script is where they start to make the meaning, right? So an actor does not just get up on stage and go, analyze spoken narratives and written records of such. I memorized that, that must be right? So they make meaning from it. And one of the things I think with education generally, and not just medical education sometimes, is giving someone a script and saying, this is a better way to say this. So like I was listening to you saying gender affirming as opposed to gender confirming or transgender, right? That's a better way to say it. But if you have not kind of taken it in and thought about it, it gets uncomfortable. So then you, instead of saying, do you have sex with men, women, or both, right? Which is one of the accepted ways to kind of like neutrally put it. If you're uncomfortable with that, you might skip that step and just go like, just sex with men, right? Like, you know what I mean? Like, because that's easier and you have not rehearsed the script and made meaning from the script. And so that's part of what's going on there with the no alcohol, right? Like that wouldn't be you because I don't want to sound accusatory, and even neutral can sound accusatory. Because if I suddenly am like, oh, how's it going? Do you use alcohol or tobacco? You know, like suddenly I've changed and I'm accusing you of something, right? So there's a complex human interaction going there. But that's why the script is never enough, ever. As you are performing, so you have to take that and turn that into, and it looks different for everybody. That's the other thing we miss, is that like, you can't do it my way. Like I'm sorry, might be that, but maybe your I'm sorry is like, if I do it, it's like, I am sorry, please feel better, right? So you have to find your own way of being. Joanna.
Yeah, I was just thinking about like what you said about how they come in with anxiousness, but also the relationship that obviously the physician knowing the patient, and so it's like the kind of relationship you build with the provider that would influence what you say, what you divulge, and form. And I mean, the lens that I think a lot about in medicine is race.
and the effects of race. And so when she was saying like, oh, you don't do this, I was thinking you're white. And honestly, like there's assumptions that are made on both ends, and I'm kind of oversimplifying, and that's my way of, I kind of assume that the white person doesn't do all these things, and you're a professor, and all these other things that you make the assumptions that you're doing, So I think that
Absolutely. And I think what's come to be called the opiate epidemic or the opiate epidemic has upset a lot of those things where people who were assumed to be the good girl or the good boy or the professor wouldn't be doing those things. Why would I ask questions about opiates, right? Because of course, Christy, of course not. And it turns out, not you, but it turns out that there are people who are from a different demographic than was expected, who are not even being asked the questions or that turns things around.
And the other thing is coming to the focus of the rural. Trying to imagine what that would be like if you're pretty much going to know almost anybody that you come into contact with in a small town. How different it is when you assume that you're not meeting somebody that you don't know in a different context. It just change entirely the performance.
Absolutely. And so you all are really good students because you're taking all my segues from me, of course, which I love, right? Because you're going right where I was going to go. But I want to hear from Gwyneth, and then we'll go right there.
I was going to say, I think it depends a lot on the agenda of both the patient and providers, how the performance goes. So if you are like a psychiatrist, you have longer appointment times, you're trying to really pull out what's going on with the patient versus an emergency setting, you really want to get to the nuts and bolts as a provider. And then from the patient as well, usually their outcome is they want to not get anymore, or they want to they want to be better, they want to whatever it is. And I think that they will perform their part in different ways to get that. So if I'm a patient, I usually use the right jargon so that they know that I know what I'm talking about, so that I can get what I want quickly. And people will take it seriously and they will treat me as someone who's educated in medical things versus, or somebody that might be in chronic pain. And so they feel they have to show them what chronic pain looks like, even whether or not they're actually feeling that expression of it. They feel like they might have to perform that in order to get their pain treated or get it taken seriously.
Absolutely. And they may also have memorized the scripts that perhaps a drug-seeking person who is not in pain uses, so that they don't use those and get confused for someone who is drug-seeking, right? So someone who has a chronic condition or a disability probably has learned not only the things that will get them what they want, but also the things don't say that because it'll go another way. And I think that's probably true in all the specialties. Yeah.
Yeah, I was just going to say, I think that when you were talking about anxiety, I felt like, losing words, but so much anxiety about the performance itself, not just about the body and what's happening in the body and what it might mean, but anxiety that the performance won't go the way you want it to go. So I think I kept thinking about power, right? The role that power plays in how you negotiate that. And I think for as long as I can remember, that interaction has been so overly staged. I experienced medical encounters in multiple ways. This is the performance. I know that I'm doing the performance to get what I want, and then there's a part of me that hates that I'm relying on all of these things to mobilize my credibility, right? To get what I want and need, because I know I'm using race, class, and certain sort of proximity to masculinity in ways that allow me to get access to that, to get what I need in really conscious ways. Yet it's so full of anxiety.
Yeah. So Anna Maria, and then we're gonna talk about rural.
So just a quick story from clinic. So typically when I have a new to establish care patients, I've never met the patient before, I don't have a relationship with them, they fill out kind of a sheet that says this is your past medical, this is your medical history. The second side of the sheet has their occupation on it, so it's not something I see. I can see their handwriting from the get-go. I can see if they spell their medications right, that kind of thing. That's kind of the only thing on that front sheet for me. So I try not to assume anything. So I'll start talking to a patient, and then what's really funny is I just assume that they don't know medical jargon, sort of. So I kind of ask the same questions, anything ever happened to you, hospitalized, kind of things like that. But what's so funny and totally, like, I'm conscious of this now, especially after the workshop we did last time, but how, like, it'll be revealed halfway through that interview. Like, they'll say something, and I'm like, normal people don't say that. Like, medical professionals say that, or, like, a pharmacist knows what that means. And it totally changes then my language and the way I am acting towards the patient, because I can kind of cut through, like, I can basically speak in a different language, and it changes. And then sort of it's like this, and this sort of happened here, like, well, I know what you want, you know what I want. Like, there's sort of this hidden agreement that we're just gonna talk through this stuff, but, like, really, you want this and I want this, and okay, like,
because it's changed your relationship. You're both now performing in the same play as opposed to performing for stuff.
so it's always interesting when the person doesn't immediately reveal that they're in the health profession, and then I find out, like, later, right? So I think that's an interesting.
And we probably all have stories, and I could share some with you about, because I'm a doctor but the wrong kind, right? So I get mistaken for a medical professional, and then they think I'm stupid. And that just happened to me last week, where they're like, "Why do you not understand the whatever pathway?" And I'm like, "Other kind of doctor, like, I don't know." But so we are here to spend a fair amount of time on performance, because it makes sense once you talk about it, but it's not a way we usually talk about it. But you've all been very open to thinking about that, which is just exactly what I want, is seeing how it really is a performance, and it's not about faking. Certainly you can fake a performance, right? But really it's about what we're doing all the time. So going back to your drawing, and you don't have to draw, but what do you imagine outside those walls from what she told us? You can just tell me. So what do you imagine about outside those walls? And I would say, like, there's a hospital attached to this and everything, but, like, what do you see? What are you imagining? Anything. Matthew, you look like you're ready to talk.
I mean, it's just striking. I imagine nothing. Because I think of it as such a self-contained world. And the times I've been in ERs, it has just been my entire consciousness, because I've been there for extended periods doing work. And there isn't a world outside. There's just a door that opens and closes. And people, and I mean, this is something that says a lot about how people who work there think of it. Well, maybe not. How I think of it, as very cut off from the rest of the world. Sort of a black box that things to and out of, working in a black box. I know that that's not the case, and that the whole point of this is to situate it within flows and structures. But the fact that my initial thought was, oh, nothing. Striking.
That's really beautiful, actually, to think about, like, what's going on in the ER is so crisis oriented and immediate. Like, there is no media that the media is in. There's nothing. It's just that. Okay, so nothing is one possibility. There's nothing outside. Anna Maria.
But as soon as he said that, though, I thought, well, are there windows in emergency room? And, like, being a provider in the emergency room, like, you lose complete track of time.
Yeah.
Like, you don't know what the weather's like outside. You don't know what it's sunset yet. Like, kind of the weird space to be a person working in. I was thinking, exactly right. Yeah.
Okay, so there's no in or out even. There's no passageway to the outside world.
And two, this is from where I drew myself as a student drawing, so that's kind of where. But certainly, if you had asked me, like, Isla's perspective and what does she see outside the ER, that answer to that question.
I was picturing very rural areas in Missouri where I grew up. And, you know, you might have a single main street, and you might have farms that were separated a mile or two. The closest pharmacy might be miles and miles away. So I was picturing a fairly remote area where there would not be centralized resources that people might need after they left the hospital.
Anything about, can you imagine, so if I tell you this is in Western North Carolina, do you imagine anything about what it looks like, what it smells like, what you might hear?
And the first thing that came to my mind was trees and mountains and treacherous, smelling those treacherous terrain.
So
Just gonna say Shenandoah is not open. Is it anywhere near there?
it's Southern Appalachian.
Oh.
Shenandoahs are a little bit up, but yeah, but similar terrain.
But they look pretty much the same.
Yeah, Virginia. Gwyneth Virginia is going to talk.
I did a lot of work in Southwest Virginia, so there's a quick walk to the hospital in Morton. It's like Virginia, Kentucky, which is probably the same about, you know, probably directly north, I'm guessing, of this area. And it's just this, like, I mean, it looks kind of like a library size, maybe. Like, it's got like a one pit parking lot in the front. You've got the ER with maybe 4 or 5 beds. I read there's no obstetric services anymore, so I'm guessing it's probably like a 2-story building with like maybe 10 to 15 beds total, including the ER and a helipad.
Slightly larger, but not much. Yeah, and a helipad to get people out. So all of this is important, right? So we're hearing this story inside, but part of why we're doing performance for rural access is because that performance happens even there are performances that happen getting up to that, right? So I want to go through some questions with you and just think about like what it means to look at this story of rural access through performance. And for the moment, since we've talked a lot about performance, I'm going to skip over the questions I have about intersecting identities. We thought of a lot of what I would have asked you, but I have some questions I can share with you later. But I want to talk to you first about something that Joanna brought up, which is privacy in a small community, right? And if you did the reading, you saw that the GFED article talks about stigma when seeking healthcare, that they may not want to get healthcare from people they know, they may not want others to know they are getting healthcare. What kinds of things have you come into play in your experience that could lead you to imagine what privacy or confidentiality might look like in a very rural area? What do you imagine? Oh, good. I don't know. Oh, okay. So what I'm asking is, even if you haven't worked in a rural or underserved or remote or isolated area, what can you imagine would be the problems with privacy? Erica?
Sure. So in rural communities, people are often connected in many different ways. So a patient might be known as your son's soccer coach and the husband of your daughter's piano teacher, and your kids swim together, and you see them at church on Sundays. So even if you might promise, by your profession, that you're not going to reveal patient-specific information, you're still a member of that community who knows private information about them. In terms of other experiences, both working in rural areas and working with professionals who work in rural areas, I think one of their big challenges is how to address interactions with patients outside of the medical setting when the patients themselves initiate a conversation about something that transpired within the hospital or within the clinic, in a way that's respectful of their privacy, and is also socially appropriate in that moment.
So what Erica just pointed to here is exactly the difference between privacy and confidentiality in a rural setting, which is, you said, even if you as a provider promise, which is confidentiality, right? Like, I promise you I will not tell anyone. That has maybe little impact on privacy if everyone knows anyway, right? And then that can get turned around on you when you run into someone in the grocery store and they are the ones initiating, and then you suddenly have to raise this question of, can I respond within the bounds of confidentiality? Is it private? Is there other people around who see us talking? What is the ethical thing to do here? What is it? So privacy and confidentiality don't always come together. In fact, they more often don't. And then it leads to problems that you might not see in a bigger space where you're not going to see something.
So, I grew up in a very rural area, and I spent a lot of time in the rural hospital. So this is exactly like you described it. And my mother worked in the lab. So a lot of times when there wasn't childcare, I hung out in the lab, and I knew how everything works. When I got my appendix out, my mom brought it and showed it to me. And so I knew everybody. And also, my mom would talk about what was going on in the hospital at the dinner table. So a couple of times I went into the ER, and there were certain people that I knew, because my mom was on the panel for, when infections get spread around and they figured out who did it. So I'm like, I don't want that person to touch me. Like, you just know way too much. And that can be good or it can be bad. And, because my mom worked in the hospital and she knew who was the best and what to do, she got us access to things very quickly. That had its upsides and its downsides. But, and a lot of the other people who worked in the hospital, well, we all went to the same school. So I knew their kids, and so it was just very interesting. That way, this reading brought all that back. And then one other thing that happened, this is a very tragic incident, but my grandmother, who lived up in the mountains in rural Washington, she was shot by her caregiver's stalker boyfriend. And so then he was shot by the police, and he was helicoptered to the hospital, and my mom was on call. So she was treating the person who had just killed her mother. It sounds like a soap opera. And she didn't even know. And then she heard what was going on, because then my grandmother was brought there. So, these stories, like some really horrific things can happen. And then she still had to do her job because there wasn't someone else. So, imagining the stress of the people who work there, who might have very close relationships, to the people who come in and having to manage their emotions, and even if they have a very strong, bad relationship with someone, they still have to and they have to act like professionals. So, I think the intensity, because we did this the last visit, but so much of that came back to me in the
So you're pointing to another thing that might not happen in an urban area, which is you have a conflict of some kind with someone. So I know this patient, either good or bad. It's probably not a good idea for me to treat them. I can call in a colleague. If you're in an underserved or remote area, there's probably not someone else, right? Or maybe the patient says, I don't want to see you, right, for whatever reason. And there might be an option if you're in a better served area, but in a not well served area, you might have to say, I am it. Like, here are your choices: treatment or by me or no one. So going to Isla's story, where can you see performances that are trying to hold together an idea of confidentiality or privacy or both? Where do you see that in her story? There are several places where people are, and you talked about, like, I have to step up my performance. Okay, now I have to perform this. Where do you see them, like, really trying to make it happen, knowing that there's this, that the stage they're on really doesn't allow them to do that? Right?
This doesn't exactly answer your question. I'm sorry. So there's a number of different instances with the curtain, I think, that we can talk about. But one thing that struck me earlier when you were giving this introduction, you would use the word lurking to describe people in the emergency room, and then you quickly said something about the physician working, and I was kind of like, well, they sort of interchanged in my brain a little bit. And so, like, I think about, like, medical students or myself, like, say you're like, so probably not this emergency room, but one in Chicago, there's multiple physicians at that center table. You're not assigned every single patient, you are, right? So you may be working at the physician station, but you're kind of lurking, finding out what your colleague is taking care of, you know what I mean? So, like, oh, this interesting case came in. And so you're kind of working as a physician, but you're also lurking. So that's more of an urban setting kind of thing, but that's kind of interesting.
And it's something our trainees report a lot, and probably yours too, that sometimes they feel like I'm just kind of standing here, like I'm supposed to be learning by watching, but I feel like I'm lurking.
Right.
I feel like I shouldn't be here. Like the X-ray tech, like, was he kind of working, but he was sort of, it wasn't anything else to do. He was kind of talking to her. Yeah. Okay, so the X-ray tech is one person. Matthew, you look like you're ready for the mic. Like, sorry.
I just want to come in that last part first. The parts where it doesn't sound like they're working, they're still working, right? So that the reassuring chit chat, that's also a performance, right? And this is part of it is part of what they do. It's part of what makes the X-ray tech good and effective is able to. So while the questions of privacy are complex, they're also reassuring, and the intimacies here. It goes both ways, right? And what was interesting, the really wonderful moment in this is where she says, the only time where I wished, I felt weird at that. That was the only point at which I felt, it's funny, but that's the only point at which I felt like I should not be hearing this conversation, was about emotional pain. And sort of feeling voyeuristic in that moment. But she sort of accepts that, well, it's an ER, things overlap, there is flow, it's chaotic. This isn't your doctor's office. And there's a sort of measure of charity there that it's not going to be what it was and what it might be elsewhere. But as soon as there's a question of expression of emotional pain or suffering that she ought not be privy to in some sense, that's when it becomes an issue.
And she is very clear that it's like you said, like I she's watching all this, and then it feels strange. That like kind of quietly watching is a performance as well, and it's disruptive whether or not she shows it. When this new moment comes in, and she's like, I'm audience, this is wrong, right? And that may be just an internal disruption, but she's performing that for us in the story, making sure we know that there was a disruption, even though she probably didn't look different in the moment, watching. She probably didn't go, right? But she's telling us later, I felt bad about that.
I found the conversation with the woman who came into cleaning to be particularly poignant.
Yeah.
And I think it's because you don't really have a script for those kinds of moments. So they had a pre-existing relationship where they were equals, and then all of a sudden, one's a patient and vulnerable and doesn't want to say probably a lot about why they're there, and the other is a little bit embarrassed that she's cleaning the space. That was one of the most poignant moments for me.
I interrupt quickly. We have about 10 minutes before we're supposed to take a break and move on to the pedagogical part. Do people not want to take a break? Do you want to take a break? What do you want to do?
I think
What do you want to do?
I think we should take the break. If I can just go through a few more questions, I think I can manage to take a break to the pedagogical. Is there another?
I was just going to comment on when both her and the doctor know that the doctor, like, he comes in and pretends we talked to her doctor, but didn't, and that she knows that he just was late because of the death of the other patient, but pretended. So it was like that privacy, kind of like, you know that I know that saw that, but and I did talk to them, and they just both play along with the game. That something happened that didn't happen, what actually did happen didn't really happen, or she didn't see it, and it's obvious that they both knew more than they were.
Right, and they kind of agreed the performance, right? Like, I am saying that I am here now and nothing just happened over there. Okay, I'm letting you say that, right? And I think similarly, the conversation you brought up, there's a lot unsaid. I see you cleaning, I know we're equal, I'm not gonna get into it. I sleep in the bed, I know something's up, I'm not getting, there's a kind of a performance of, okay, whatever you're saying to me, I will accept that. The curtain, the offer of closing the curtain, huge, that's just a huge performative gesture. Let me protect your privacy. Absolutely not, right? Like, the curtain does nothing because so much is heard, so much is seen. She's already been seen coming in. But that's that very important gesture of, I am trying, right? So part of this, and thinking again in this rural area, where it's going to be almost impossible to protect confidentiality, to like give us standards, just because of how few people there are and how tightly knit people are, those performances become more important, right? To say, I know I can't keep the whole town from knowing you're here, but I will shut this curtain to show you that I care about it and I will do what I can. So I think some of those things that we might take for granted in an urban area or a better served area become very, very important. And this is like fences make good neighbors, all the things that people talk about when you live in close quarters. There are ways that you're like, I didn't see that, and that's how we're going to stay good neighbors, right? Like, I may know that, but I don't see it.
I think it's also interesting. I don't know if I said this, but like, my background, I've been in ER nurse for 7 years. And as providers, we sort of decide who deserves privacy, especially when you have varying degrees. So if you have rooms with curtains versus patients in the hallways versus patients with actual doors versus this brand new ER we have like separate waiting areas for families in distress, or we have like a viewing area for patients that have passed. And so all of these have various sort of like both physical, like sound, environmental barriers that change privacy. And we especially as nurses, we decide where patients go, if they go in the hall versus if they go in a room with a door versus a curtain, and like how much privacy do you need, how much privacy do you deserve. A sprained ankle, you can go in the hallway, you don't need privacy, but somebody that has explosive diarrhea, like we want you to have a door, right? And so it's like interesting that we sort of decide privacy based on, I would like to think it's medically, but you know, that's a question is like how else do we make those decisions about who deserves privacy and who deserves hushed voices when we speak versus regular tone, and kind of those decisions that we make about even.
So what does Isla deserve? Like, what sense do you get of what she deserves? How is she regarded in terms of kind of the hierarchy of who deserves privacy, respect? What does she tell us that makes you think she occupies a certain status or not, the patient?
Right at the beginning, she tells us that she thinks she's being treated as a VIP because of who her doctor is. And then later said, well, that probably wasn't the case, but it still felt to her like she was getting VIP treatment.
So not clear, but she thinks that, and her doctor at this time was the chief medical officer of the hospital, right? So it was a little in-joke because that's who's interviewing her, right? It's my friend Jen, but also saying like, I think that actually might have mattered, right? And sometimes it's not clear, you can't tell, like, would that have mattered or not? Anna Maria had that.
I was just going to say, as a provider, what's really jarring for me, because most of what I do is in clinic setting. So I have a door that I close, and I have a private conversation with the patient. And for the most part, you can't hear, maybe if someone's like outside the doorway with their ear pressed against the ear, but it's a very confidential setting. And I get very taken aback. So I finish up the important confidential conversation stuff in the room, and I walk the patient down the hallway to the checkout. And usually it's small talk that we talk about in the hallway, like how are your kids, blah, blah, blah. But it completely disrupts and disorients me when then a patient will turn to me and ask a medical question. Like, oh, I forgot to mention that rash, but now we're in the waiting room, and now there's no privacy. And I'm like, what? So sometimes I'll like walk the patient back to the room and be like, okay, here, close the door. But like, it's so disorienting as a provider, I think, to know like what I'm supposed to do. But in this kind of setting, like you don't have those options. So I think that completely changes what it's like to be a provider and be uncomfortable in the patient. So
sure. And how do you draw the line? How do you separate out what's medical talk and what's personal talk? When you know this person just fixed your boiler in your basement the other day, right? Like, there's no use pretending they didn't, but how do you separate that?
Most of our hospital staff in private rooms, but I still work in a hospital at Dublin, and we have curtains. And I was called this weekend admitting patients with issues that were it's still very uncomfortable for me because I do hold the curtain. And we're having conversations with the person in the room with the family member and here. But it goes to that same, sort of sense that we just have. And it's best we do under these difficult circumstances.
So anything else about Isla that you think gave her status or took away status? Just from her words, we're going to play a little bit more about her. One thing that we've kind of talked around, but that is almost certainly true, is she was known, right? So not only was her doctor someone known to the hospital, but she was known as a person from town. She was not an outsider, which could have worked for or against her, right? Like an outsider showing up in a small hospital, maybe you would treat them with higher status because you're not sure if they're important or not, or maybe you would rely on old biases to be like, I don't know who this is, maybe they have lesser status than me. Like, I know, but she's known, and so she's treated as one of us, right? She's also, again,
So she's self-effacing.
okay,
She's not demanding.
okay.
Betty?
Sorry.
So she's self-effacing. She's not demanding.
Yeah, she comes in and says, oh, I think I might be having chest pain. She doesn't say, I need opiates, or I need to be admitted.
Right.
And so she's already sort of inhabiting this role of a good patient.
Right. And she's willing to wait. She's compliant with everything they ask her to do. She's hooked up to the leads. She's nice to everybody. So she's absolutely performing the role of a good or compliant patient. She's also, as you can probably tell from her storytelling, Vanessa, she's very articulate. She's very well educated. So she's able to not only tell this story to us, but tell her story in an organized way to her providers, right? Which automatically makes her easier to care for. Whether or not that matters and should matter to the kind of care you get, she is an easier person because she can say, this is what I think is going on. She's not hiding it, she's not disseminating, she's not there. One thing you can't possibly know by reading her words, and in the past I've played a little audio of her, and hearing her, you can't know this, is her ethnicity. And she is not white. And in the teaching guide I'll share with you later, she talks about her ethnic and racial identity, but she passes as white. And this is important in a small community that until recently has not been very diverse. That she, again, seems like one of the people who has been here for a long time. And I think she's very aware of that, and she talks about that. And you brought up the whalers earlier, and we didn't talk very much about the Latina men and women who are kind of wailing, and that's in air quotes kind of, because she's very aware that her quiet, compliant, not demanding whiteness, appearing whiteness, even though she's not white, is very differently perceived than these folks who are running back and forward and have no translators. They certainly have no privacy, since you can hear and see everything going on. It's a very different treatment. Alex.
Can I also ask you a question? Because you brought up the opioid crisis a couple of times, and we're talking a little bit about geographic region and rurality, but if this hospital is in the Appalachian region, which is hit particularly hard by the opioid crisis, like what sort of specific role does that play in this? I mean, this is more a rhetorical question, I guess. It's not it doesn't have bearing on like finding the truth or something, but it just seems interesting to said it a couple of times. Kind of relevant to the specificity of the place.
So first of all, there's no truth. Second of all, you have to say Appalachian, not Appalachian.
Okay, good to know.
You can say
No.
Appalachian.
Appalachian.
Pronunciation.
Yeah. I'm just teasing about
No.
Both are accepted by the dictionary. One is wrong. So Appalachian. This area is very hard hit by the opioids, and so I'm going to use this as a question to y'all. Getting back to like, what do you imagine about this area that might make it a place that is hit hard by addiction? And before opioids, there were plenty of alcoholism, plenty of other drugs, right? So what do you imagine about this place? And some of this you might have gotten from the Do That article, and some of it might be from your own experience. What are the kinds of things that lend themselves to being a place where addiction takes hold in a large number of people? Poverty, unemployment, nothing to do, isolation. Those are the big ones. There are probably some more, but poverty, nothing to do, isolation, unemployment. So a sense that you are alone, that there's no way forward, that there's no way out, right, can lead to finding an escape in another way. One thing that we have not talked about, and I would encourage you to look at maps, and we've talked about whether maps would be a good part of this presentation, and they would be, is how isolated this is and how hard it is to get to. But in some ways, you can get to it pretty easily. Because there's a new highway that's gone through that makes it like not as hard as it used to be. But there is no OB service there. And some of the readings, the additional readings talk about that as well. They canceled the OB service because people didn't want was the corporate answer. And it really wasn't making money. So a woman in labor has to go down what's called the Devil's Highway, about 20 miles to Marion. And it literally goes like this, just a series of switchbacks. So So if it's icy, which it often is, it is impassable. So then they would have to go much farther, kind of north to get to healthcare. So everyone in that town has predicted that there will be a maternal death. There just absolutely will be, because the only other choice is to move to Asheville or Marion, which most people don't have the money to do. And so there's almost certainly going to be someone who delivers on the way, doesn't make it, can't get there. And they had a wake where the whole town came together, most of the town, and lit candles when the day that OB service closed. And they said, this is in, because we know this is going to happen. This is, yeah, exactly. Exactly, and it was really moving, and it made national news and everything. But they just all stood together in like a town center place. That like, we are mourning the closing of this, and we are mourning the death of one death of people, because it is that remote and isolated. And this is one of the main things. And the Guardian article that we added for this that talks about Eastern North Carolina, which is totally other end of the state, but just shows you like it doesn't matter kind of which remote underserved area it is, there are some things that are shared, right? So in that Guardian article, if you had a chance to read the extra one, was about a woman who died of a heart attack because there was literally only one place to go, one road. So what I would ask you at this point, since we're coming up on time, is give me some takeaways to you about, so we've got performance in our head, right? But like, what are the things that affect the performance of healthcare? And that might be the way a system works, the way a patient behaves, the way a doctor behaves, that are special or particular to a rural, remote, underserved, isolated, and that could be part of Chicago, right? That could be like some little part of Chicago. What are the things that are particular that shape those performances? And you can throw out a word, you can throw out a phrase. What are the things that are particular to that kind of space? Access. Okay, can you actually get there? And that might mean the Devil's Highway. That might mean, is there a bus line, right? Is there a road? Do I have a car? Can I walk there, right? Like, so access in all kinds of ways. Might also need access once you get in the door, right? Can I speak literally the language, or can I speak the language that will get me what I want, right? So I can speak English, but can I speak the medical English that will get me the best care? Okay, so two kinds of access. What else shapes those performances?
Mistrust. Hi.
Mistrust.
Mistrust from the patients towards the healthcare professionals too. They feel that they're not going to understand them or listen to them or acknowledge their, feelings or the, symptoms.
Yes, and that could be based on either a long relationship that they've had because they're all in the same community, or because they are new to a community where everybody else has had this long relationship and they are not in that one of us vibe, right? So Western North Carolina is one of the places where there are large groups of immigrants coming from other countries, many of them Spanish speaking, and that has kind of changed the whole dynamic. And there is definitely a reckoning with who's been here since, the white people kicked the Native Americans out, and who's here now, right? And who are the ins and the outs, and what does that mean? So there could be mistrust for many reasons, right? Mistrust, access, anything else.
Or the flip side, trust.
Trust, okay. Okay. Trust can be a double-edged sword. You might have had your doctor your whole life and think, well, Carrie's so great. She's always right? And she's the town, I have seen this before where like, she's the town doctor, she knows. And maybe she doesn't and isn't willing to reach out. Not always, but that could happen. And you don't know to look for someone else because I trust you so much. So that trust can limit you as well. I saw several other hands. Anna Maria. Reputation.
So even here, I think about in Chicago too, like if I have a new patient that's coming, and they introduce themselves as I'm so-and-so's daughter or I'm so-and-so's cousin, their sort of reputation changes a little bit because then I associate them with that person. Or I think about like the reputation that UIC has among different people. So some people will be like, I'm not going to UIC, or like get pissed because their insurance changed and they have to come to UIC. But then I have other patients from like Northwest Indiana that drive all the way to Chicago, spend the night at their sister's house just so they can come see UIC, like big hospital. So I think the reputation thing, and then certainly in a small town, like is the good doctor reputation versus like the outsider doctor reputation. So that is that. No. Oh, you want to say something? Okay.
Anna Maria mentioned insurance, and I think that's super important when we have a talked about that. I don't know if we have time, but that really influences access, but also resources of the hospital, just resources in general, really affects access.
And I will hang on to that to talk about when we talk about the pedagogical stuff, but I will say that if you have an area where most people are on Medicare and Medicaid, and one physician in that area chooses not to take it for some reason, then that comes back to access again, right? So you have to drive farther to get to a specialist maybe, or maybe a specialist just chooses not to settle in that area, which is right? The only specialist you can see is in Charlotte, which is, a 3-hour drive. Maybe you don't even go because you can't get there.
I think culture is really big in rural areas. I think this is really well illustrated in the Guardian article, which just broke my heart when the guy said the closest hospital is on the beach, but we've been conditioned not to do beach traffic. So I'm going to go to the one that's 10 miles further away so I don't have to deal with beach traffic. Or we know that if we call EMS, we're going to go to the beach one, and we don't want to go to the beach one. But in reality, had they called EMS, gotten an EKG, they would have called a helicopter and she would have flown somewhere and she might not have died, and all the tears this morning and culture.
And I will say that I think the Guardian wasn't as clear as it could be that that's for real. Like the beach traffic, it wasn't just I don't want to go to the beach traffic, that's annoying. Stand still. You would get in that line and you would just sit there. So he was for real, but not knowing but there's an option for a helicopter, right? Because you just had it in your head. You don't go east. You don't go east. Go to the west. So he was using the best information he had, but that's hard information to change when generations of people have known X and not known. It's just going to add to my privacy, I think, is one of the biggest things. Yeah.
And we've talked about this, but I think that the multiple interlocking identities,
yes,
that's huge. I mean, I would guess, the church community,
yes,
your school, a lot of multiple interlocking worlds that make it very complicated.
And that is directly related to privacy. In a small community, tight-knit community, it is impossible to be one thing. You cannot be one thing in the way that you might be able to in a bigger area, the doctor. Impossible. You are so many other things, especially if you grew up in that community, right? And even if you came to that community, you become the person, right? You become the person who wears, fancy shoes, or the person who never tips at the, restaurant, like that. So you cannot be one person. Okay. You got Erica or Elsa? Did you want to add anything?
My comment was going to be similar to Christy's, the other relationships that you have.
So let me give you just 4 things to think about, and I think it's always helpful. We've said a lot of these, but when I teach, I always like to give some kind of takeaways. And these are all in the materials you gave, but it's just helpful to say, so these are some of the things we talked about. So healthcare in a rural, remote, small, isolated, all those words are important, right? And it can be one and not the other. It can be urban and isolated, right? And a small community, it challenges ideas of privacy and confidentiality that prevail in more densely populated areas. And if you think about HIPAA is written on the idea that you can just be doctor and patient, right? Which you cannot in this area. So it really challenges those ideas. Access to healthcare in rural communities is often limited by both options and geographical distance. So those are both important. We can talk for hours about that. Not just geographical distance, but options. This is the only hospital where Isla is. That's it, right? Identities are closely monitored in a rural community and at the same time are complicated by multiple social roles, right? So it's not only that you're playing multiple social roles, but everybody sees you all the time because there's only one main street. There's only 3 other ways to go. So it's very common for someone to be like, Christy's not home. I saw her leave earlier today, right? So I'm not going to go up and talk to her because I saw her leave. That could also happen in the neighborhood in Chicago, right? And then last, performance studies, which is what we started with, just remembering that it allows us to look at human activity and behavior as performance. It doesn't mean faking. It means making something happen, and providing healthcare and actually receiving healthcare involves multiple kinds of performance. So it's one way to look at things. We can certainly use other lenses, but the reason I chose Isla's story for performance is because she is performing for us the story of being part of a performance. which I just think is part of it. She's a college professor. She's really well educated. She's so good at telling a story, but like she's able to get at the meta level of, I am telling you about watching this performance happen. So it seems like a perfect thing to pull apart with performance. So that's where I will leave you all, and I'm only 6 minutes. How's that?
Okay.
Okay.
All right, we're going to take a 10-minute break, and I'm going to pause. Okay. Come back in 10 minutes.
No, it's, I think.
Well, so she
Come
did
back.
it or like whatever they wanted to do.
I also asked it.
She did it was elevated. So then I was like, oh my god. So then I ended up ordering for the thing. And then she had house bacon. But like,
Continue to eat.
we have plenty of food. And then my like video.
That's
Sandy,
amazing.
I like the yeah. Oh, good. That's
A la Shea.
yes. Last time I ate.
What was it?
There was too many like cookies and pastries. You saved me from myself. Thank you, Shay.
It's a good influence.
Shay's the bomb. I'm telling you, I couldn't do this project without Shay.
So in this section, I don't know if you want to introduce what you'd like to happen in this section, or do you want me to just say what I think is going to happen? Yes. We've had many Skype conversations where it's like, what do you think we're doing? What do you think we're doing? So in this section, what we wanted to talk about was how you might teach this to medical students. I think your biggest challenge is going to be that there's tons to talk about. Like there's so much we didn't get into enough. And I also think that that means that you could teach this a lot of different ways. And to me, the biggest thing is even getting at the idea that rural, underserved, remote is different. That you cannot just, we were just talking about a TV show where like someone from New York comes into a small town in Alabama and is struck by the differences. And that is one of the main things, is the idea that you have to perform, think differently when you are in a setting that is not an academic medical center in an urban place. And keeping in mind for students all the time that a lot of the things that are built into the way medical care is delivered, at least in the US, are based on the idea that you are at an academic medical center or in an urban setting and have resources.
What I'd like to ask Elsa and Erica to respond to is, we have a really interesting situation at the University of Illinois because we've got 3 campuses, 2 of which have rural medicine programs. And we're an urban medicine program here in Chicago, but some of our students may choose to go and work in rural areas. So we have a bit of a different flavor to all of our campuses. And I wonder if that would also raise the question, would the needs be different in terms of unpacking these issues? So I wonder, Elsa and Erica, would it be helpful to share with us what you all do now addressing the kind of issues that we've raised here?
You're on the spot. You know what?
I can start. So what I've been doing with the medical students is to have an active discussion about what the differences between, because the students, most of the students come from urban or suburban populations, so more, and then the patient population is more rural in this area, especially because we get a lot of transfer from, from Iowa until Danville in South Illinois. Southern Illinois. So what I do is having an open conversation about the stereotype that come from belonging to different groups in geographic locations and the expectation that comes with that, and having more personalized small group discussion. And I do that during family medicine clerkship during them 3 years. And some of these the students actually in family medicine go out to the canton or the rural communities to practice one-on-one with the physicians. So I think having an active conversation about stereotypes actually and the expectations actually has been very helpful with our students.
Thank you.
And with my affiliation with the university, I'm not full-time faculty there, so and I'm not directly involved in the rural medicine program myself, so I can't speak really quite honestly to a lot of what they do. I can say that within the ethics program, in the past during the M2 year, we have a 2-hour program dedicated to ethics and culture, or we did, and where we explore some of those themes. And then we've used some case study examples to illustrate some of the particular challenges and opportunities in rural communities, particularly related to confidentiality and privacy. But they may be doing more within the rural medicine program. And I since I'm just not directly involved, I wouldn't be able to speak to that so well.
Yeah, and to clarify, I'm not involved with the rural because there's a selected group of students that apply for that program. And then Dr. Barnett is the one who leads that program. I see them, all the students during the family medicine clerkship, so I have a good grasp. And they tell me that is along what they experience during these rotations. And it's very helpful to actually learn from the, having an urban perspective, learn a little bit about what a rural community struggle with.
So both of you brought up things that I think are really important, and then I'll come to you, Anna Maria, but to my friend Anna Maria, I'm sorry, Anna Maria. Thinking about stereotypes of rural areas, so those stereotypes sometimes are of people who would be coming as patients. There also are stereotypes of who works as a doctor in a rural setting, and the stereotype is often like someone who couldn't go anywhere else, right? And that's one of the things my friend Jen struggles with is she was, top of her class, chief resident of Rochester, she's fantastic. She went back because she loves rural medicine and she loves her hometown, but she's treated as very stupid, right, when she talks to someone from Duke or Chapel Hill. So talking through the students of what do they think of a rural area, and not forgetting that they might think the doctors, and we hear that in Utah too, oh, this guy from Moab called me and he doesn't know what he's doing, and it's really, he knows what he's doing, he doesn't have an MRI machine, so he can only tell you what he sees, right? So talking through about that, and also thinking about, so our rural health that we're just starting this coming year in Utah, I was just saying something with about it, they're pairing with global health for a number of reasons, because global health is often also about working in underserved, under-resourced areas, but also because many people who immigrate to this country come from rural areas. And so even if they're living in Chicago or Salt Lake or New York, their upbringing, their understanding of medicine, their view of the world has been shaped by a rural understanding. So understanding rural medicine may be very important for people who are coming from a different place, right? Because that may change the way they think about what's possible, what access is, what a doctor does, right? So both of those things could be things you'd want to address. I would say with any group that you start with, you would want to start by kind of getting an idea of what do you think rural is? Do you have any experience there? What does that mean to you? That could be an activity as well. I see Erica and Anna Maria and how's that? So Anna Maria, Erica, and then you.
I just had a question about what level of medical students, I'm thinking M1 to M2 for this type of thing, so
pre-clinical.
Right.
Yeah, so that's another thing, we started talking about, there's no typical M1, you're gonna have M1s all over the place, but most of them will not have had clinical experience, so the drawing exercise might be very, very different, right, where a lot of them are well, I saw one time when I went with my dad, so that can be a kind of setting norms experience, what do we all think an ER is? That can be really helpful. Erica?
Yeah, I love the invitation for reflection around what students' biases might be or what their impressions might be of rural community. In my experience, I've actually heard comments from fellow faculty members implying that rural people are less educated, are generally speaking racist, don't have as much worldly experience, etc. So it seems like we might even have a disconnect on the faculty level sometimes as well.
Absolutely, I think that's absolutely true, and worth maybe thinking about. Maybe that's something to even say to students is going back to this idea of do you always trust your doctor or do you always trust your teacher? Being able to say, wait a minute, is that really the way it is? That can be hard to do, but maybe even just putting in their head that someone might say something to you like, all the doctors from Peoria are stupid. Maybe questioning that, right? So pushing back against that and knowing it's a good question. Sandy?
This is just back to a point you made about 3 or 4 minutes ago. One of the things that came out at the Humanities Frontiers discussion was whether or not we should, or maybe it was just a private discussion, but whether or not we should not call this portrait rural population and access to care, or should it be about under-resourced population or setting and access to care. And you made a really good point that you just, you referred to with the combo of global medicine and rural medicine, but I wonder if you could speak to that, or if we could even just ask students their thoughts about that.
So I'll just give, so because I've been hanging out with the rural health and global health people, I just found out, do you guys know Park City? It's a like really fancy ski resort. Their hospital is considered rural and underserved because of their population density and the wide range of, because like if you go east of Park City, there's nothing, right? So it's just kind of hilarious that this like really fancy town with the highest per capita income of the whole state has a rural underserved hospital because of who they serve. Vail, so similar Vail, another like ski town in the middle of nowhere, right? But like there may be better words to use to introduce this so that students don't stick with the urban rural, but are thinking about what are the things that are often present in a rural setting that are also present in an isolated neighborhood, at an in a state with a like not much of a budget, in a refugee population that is underserved in many ways. Allie, you had to find the microphone. Parts of Southside Chicago, absolutely. Same reason, right?
That seems to get at one of the questions I had about how to approach this is how you address both like individual biases, but also introduce or help students with structural content. And I think maybe it's because most of my experience is working with undergrads, like there's something about, they're really quick to say like, oh, I get it, bias. Now I just changed my perspective, my view, and now I don't think that way, therefore the problems will be solved. So it seems like that question about how to complicate even the very idea of what is rural or what is a resource helps us collectively get at not just individual ideas and biases, but helps them somehow connect that to the structural. Because I could see them sort of saying like, okay, well, what do we do with this? We just change our idea.
Right. So this is something that comes up a lot with students, medical students that I teach a lot, is you present them with an ethical conundrum or a problem or a challenge, and then they go, okay, I get it, I heard you, I figured out how I feel about this, I can't do anything. They don't usually say, what do I do? They say, I'm just a first year medical student, I can't do anything. So then what's that?
And that's okay.
And that's
exactly.
And so part of the conversation can be going, no, you cannot, like this just happened with me. We had someone present on the Indian Health Services, right, which is a disaster and has been forever. And they're like, well, now you've told me how bad the BIA is, how bad the IHS is, how Native Americans are horribly underserved. Now I'm just depressed. I can't fix
I just feel bad.
the IHS. So yeah, and sometimes it's kind of aggressive. Like one student was like, you just want me to feel bad, right? Like you liberal, like you just want me to feel bad. And so what we were able to talk through in this small group is, no, you cannot fix the IHS today, right now. What can you do? What are some things you can do? And they came up with a really good list of things they could do, which is, okay, now that I've heard this presentation from someone who is Native American, who has experienced this, she gave me some things that I can remember to ask about. Mm-hmm. I can support some things that are already in place. Like our hospital allows Native American shamans to come in and, with some restrictions, like I think they can't burn, they can't smudge, but they can do lots of other stuff. But not all providers know that. But I, as a medical student, now know that. So if I have a Native American patient, I can say, do you know that your medicine man or shaman can come here? And my attending might not know that, right? So giving, what can you do right now? And then when you are an attending, what can you do? And then when you run the hospital, what can you do? And then when you run the Indian Health Service, what can you do, right? But like taking them away from that, you're just making me feel bad, or I can't do anything, or I feel terrible, to, well, what can you do at this point? And also it's okay, you are doing your job right now, which is training to be the kind of doctor who will ask these questions. But I think that's important. You're right, to get past just the what am I thinking too, and what does that mean in a larger context or structure. Anna Maria, you've been waiting.
So what I was going to say is I think that too, and when we getting back to the performance thing, having students thinking about their performing in a setting, like the performance is happening on a stage, so to speak, and so having them think about those like contextual issues that they're dealing with. And as a provider, they may not be able to change it, but they need to be able to perform with their patient in that setting in order to make it work for their patient. Does that make sense? So, like as a physician performer with my patient, like I know their insurance isn't going to cover this medication, but like being able to identify that, say it to the patient, have them understand that I know that the insurance won't cover it, but we have to operate within the system, within the sort of stage that we have like the limitations, right, boundaries or whatever that are like it's a systems issue. I think that's really important to get the students to recognize that, and also not be like, well, I can't get the medication covered, like, well, then I'm just not going to be able to do anything. Well, then you got to work with it, and so just being aware of those.
And that ties, I think, directly to that performance of, do you want the curtains closed or shut? Because it is an acknowledgement, and you're doing it more explicitly of, I cannot do the right thing. I cannot do the thing I want to do for you. I am being stopped, which is I would like to protect your privacy, or I would like to get a prescription. However, I want you to know that I see that limitation, and I am concerned for you, and I'm going to figure out something that I can do, right? So that's a curtain performance. I can't protect your privacy. I do not have walls. I have a curtain. I have a generic. I have an alternate medication, and I'm letting you know that I will do that.
So as I think about how I would want to use this, I think the issue that we touched briefly about, the stereotyping, seems really important to me. And having grown up within kind of highfalutin medical centers that think that they're the best and look down on everybody who transfers patients in, I now look at this issue objectively and feel like some of the very best doctors I've ever worked with are in under-resourced areas, and you have no idea how good you have to be with your physical exam, with your creativity, even Stroger and trauma care. A lot of people would look down their head at Stroger. If I were a trauma patient, where would I want to be? You look at where people are able to do an incredible amount with relatively few resources, how easy it is when you can send everybody for a CAT scan because you don't have to do a physical exam. So, I think that this issue of changing those attitudes towards each other as professionals and the way we interact with each other seems like an important part of this. And I wonder if, for me, what you've done here so effectively is expose the vulnerability of being a patient in a rural community. But what about doing a bit more with your friend, the doctor, about how difficult it is to advocate? Or is that asking too much for it?
No, I have about 25 more interviews with providers. That's just not what we decided to do. But there's a lot to say there. And one way that I think is very effective to just get at this with students is through history, which is to say, when are the major advances in medicine and surgery? They're often made on the battlefield in times of stress where, like, this guy's gonna die unless I try something new and I have a shoelace, right? Or you look at global health again, and like people figure stuff out because there's nothing to lose in a way because people are going to die and there's nothing there, and they invent and they innovate. And I pointed to Gwen because she's worked in rural settings, so I know she can talk about like how creative and strong you need to be and be able to but reminding them like this has been true all along. it's in the underserved settings that some really big breakthroughs have come that they had to bring.
Yeah, my research is actually about nursing in Pearl Harbor, and like 5 or 6 things that came out of that, not just nursing, but burn care, like how to manage fluids, and like pretty much everything that we learned at Pearl Harbor to around like burn care started in Pearl Harbor, right? Anyway, my thought to piggyback off of what you were saying, I'm glad you said it, about resources and like thinking about when you're teaching this about different types of resources. So we have like the technological resources. And then you have the individual resources. So like your as a physician or as a medical student, what are your resources, your knowledge, your skills as a physician? But then the third one, which coming from my lens as a nurse, I think is your resources as a team, as a group of people, because you're not, although you might feel isolated as a provider, you're not the only one there. You have phlebotomy, you have nurses, you might have a mid-level provider, you may or may not have a pharmacist, and knowing what those roles are and what they can do and what they might be able to stretch to do. For example, like a pharmacist, they can drop medications. You don't need your nurse to drop the medication. If the pharmacist is there, have them drop the medication, so maybe the nurse can do something that only that nurse can do. Or knowing like what can the EMTs that brought that patient in do, or what can your nursing aid do, and understanding what resources you have and how you can really maximize what you do as a team to really harness those resources to the best outcome for that patient or that scenario that
Those volunteer EMTs we didn't talk about, but I think that was really interesting too, because volunteer fire departments, volunteer EMTs are oftentimes enormous role.
So it's interesting because now I've presented this twice here, and this conversation has gone completely different ways, which is helpful to think about, because last time we talked a lot more about EMTs, last time we talked a lot more about Isla's identity as a non-white person and the Latina people in the group. And I think that's real, like, I might even just say, we're only going to talk about X. Like, tell the students we're going to focus on pages 2 through 6. I think that's important. Or maybe when we give them their pre-work, say something like, look for moments of Y, look for moments of C. Because I personally could talk about this for 20 hours because there's so much to unpack. She just does such a beautiful job. But yeah, the EMTs actually would be a great way also of getting students figuring out, like, who knows that in rural areas it's mostly volunteer, who does fire, who does police, who does sheriff, who does, all this stuff. Because students who have experience in a rural area would know that. Students who don't are often shocked by that. They're like, what do you mean? And I'm like, no, I mean, they get the call and they go to the thing and they put their hat on and they go. Like, they come from home, right? The EMT comes from home, and that's why they weren't dressed in here. So that can be another moment to say, like, what is it you understand or don't understand about how things can be. Yeah, Matthew.
So just a couple of thoughts piggybacking off of what other people have said. So the question of whether or not to call this rural is a real one. Because as the article makes clear, we don't really have a uniform definition of rural, but we do have fantasies of the rural. Yeah. And it's a useful category, right? If we have a rural health program, right, we might not know what rural is, but when we see it, but I do think it's worth, and I like the fact that sort of explicitly confronting stereotypes going into this should be done, right? Because both positive and negative, right? Because there's this sort of fantasy of, oh, the small town life, and there's actually some really bad things about that. But also, no, not everyone there is uneducated, but there is greater levels of poverty, and so making it complicated and sort of saying, look, we don't have a really perfect definition of this, but we do. It is something difficult to use, and we have to confront the stereotypes and interrogate them at the same time as we do the concept. I think it's really important. As an aside, one thing that might come up here is in rural areas, a lot of the medical providers today are international medical graduates. And again, we talked about, we didn't talk too much about the Latino folks, but another place where race is very operative. If we do end up focusing on providers, and then the sort of racism across providers, saying, well, the person, the only place they can get a job. Lastly, just pedagogically, I wonder I wonder what we gain and what we lose by sort of teaching this through an ED stage. Because ED is its own sort of dramatic place. There's a lot that happens in an ER. We make shows about, there's a show called ER right now, a show called Phantoms, or like, or some other primary care clinic.
There's no TV shows about what I do.
Right, yeah, but that is what most of us, that is how most medical encounters do occur in these very sort of banal but also highly performed settings. So making that explicit, saying like, look, this is highly stylized, but the lessons that apply here apply equally in much less drama-intensive settings.
And if you wanted to use performance studies language, you would say heightened, right? Like, we notice moments of heightened performance. I'm looking at Carrie, right? Like, that's absolutely right. So, like, it's nerve-wracking having someone quite feel here, because I think it's true. But, like, the idea is that you notice performances in these heightened moments where either your focus is drawn to it, it's performed more dramatically, there's in some way, like, a crisis moment that you, like, I might not notice that I'm performing teacher until suddenly a student gets angry with me and I'm like, I'm the teacher, I have to fix this, right? And so there's that moment of heightened. And the ED is this constant, as you said, like constantly heightened. Like they never go off heightened. Although that's something students are often confused about too, is they go on their first round on the ED and they're like that. There was nobody cracking a chest and pumping like on TV, right? But there are moments of that.
So I love that heightened thing. It's huge. The other thing, though, I know when I was trying to find sites for ethnography, one of the things I was looking for was interaction, too. And the ED is one of the places in which you see the most interaction happening between patients. Like, a lot of times you see patients interacting in waiting rooms, right, and these banal places. But then once you go back, you close the door, and hopefully you don't hear what's going on in the other spaces. And one of the things that's special about this, I think, is that thing where we don't have these curtains going across the room, and that rarely happens in medical spaces, except maybe at like the eye exam, and like sometimes when you're in the same room. But it's very rare. So I think that piece does make it a really special encounter, and it just is worth, I think, framing, and I think that's totally important.
And I'll just say again, the reason Isla came to us with her story is because we wrote a short piece called "There Is No HIPAA Here," and so people in town know that's what it's called. And she's like, "Let me tell you about There Is No," right? So maybe framing that like this really is like this is a site to look at privacy. It's not a site maybe to look at some other things about the way medicine works. But I love that. I'm also like you just made me think of a couple other things, which is I have been talking about privacy as in loss of privacy, and for many people in small tightly knit communities, privacy is a totally different concept. And why would you not want your neighbors to know, right? So like prayer chains are a big deal, being announced at church that someone's sick. Like the idea that you would say, I don't want you to know about that I'm ill or that I have a family thing, for many people is anathema. Like what they like is that, yes, and certainly there are plenty of secrets. Secrecy is a whole other thing we can do. There's privacy, confidential, and then there's secrets, right? But the idea that like, if I like was sick or ill, I want you to know because you're going to bring me casseroles and you're going to drive my kids to school. And that's why I stay in this town. So that may be worth highlighting too, that like, because we're in a medical setting, we're thinking about protecting privacy. Many people would say, like, I don't want privacy. I want you to know what's going on here. And so they might be pulling back the curtains and being like, what's going on over there, right?
I kept the microphone just for one other thing, which is that I wanted to respond to the rural question, which is that I'm really glad it's about rural spaces, and I want to, I think I have the exact same answer, which is I think it's important to frame it in terms of like, this is a specific kind of rural that we're talking about here, but I think it's really important to just show this kind of rural, partly because we use this as a social science kind of, it's a construct that we use on a regular basis. There's a lot of wonderful social science research that talks disparities research. I was just talking about a dissertation my friend did about rural LGBT folks in rural spaces. Like there's a lot that's been done in this and trying to disentangle and trying to sort of say rural isn't a thing, I think would be a problem. So I think we just need to talk about what we mean by rural. And I love the idea of then saying, and what other spaces also function in this way too. It's not just that it's rural, it's that it's isolated, that the South Side might look like this in something too. I think that's really lovely.
And I'm listening really carefully to what Matthew said and what Ali said earlier, that like don't want to reinforce this romantic ideal of the rural. So the framing is really important. Why are we talking about the rural? What bigger context does it have? What can you apply? Because it could become a like, oh, those poor people with all their privacy problems or all their, whatever. So the framing will be really important, and that would connect to whatever you do to check in at the beginning to say like, what do you understand about this? Yeah. And maybe I've found it useful sometimes even to give the rural or understood student, the student who has that, like give them a little bit more time to speak and say like, what can you tell us that you would want us to know? Because they often feel like, at least at my academic medical center, the kids from way out, like in Beaver or Twella or something like that, are like, I'm just the country hick in the big city, and they don't talk as much because they don't think they have as much to offer. So saying, what can you tell us about having to drive 20 miles for care can be helpful to even like draw that out and get it. Because I always like to have people speaking from their experience instead of I saw on TV, not maybe, but like I saw on TV, or I understand it to be this way from reading. But what can we hear from the person, which is actually at the heart of the portrait too, right? That the case is not written by someone else. But cases are written by someone else. The portrait is written by the person who can offer the experience, who's in the patient. And Maria? Oh, let's go to Joanna. Oh, and then you guys. Yeah. Okay.
We've been fighting.
Oh, sorry.
I won. I started speaking first. So I think we are in a really unique position where I have for years, being part of urban medicine, have wanted to have a rural component and have that conversation about the similarities and differences of urban and rural care in those kind of dichotomous roles, but realizing that it's not always rural as this, urban. There are a lot of likenesses, as well as uniqueness that were brought up here today that I think we're in as a college across campuses that is making such a huge effort to bring them together. I think this is a really important thing to offer, and I would say, especially wink at Elsa, that the medical colloquia would be a great, when we're thinking about when we do roll this out, that this would be a great time to Skype across the campuses. And then I like the idea of the diagram, like what do you think of this? But then I would like to get into really like those that pulling out from those students, because there'll be rural and urban at both at the different campuses, and really getting them to speak about their experiences. When we also have this kind of reputation that Chicago's like the big monster that comes and tells everybody how to do the curriculum, and whether it's right or not, and I think we're really trying not to be. There's a different relationship across the campuses that the students also embody in some way, that I think this would help break down that assumption that the urban knows by putting the focus on all the rural people with that background. The other piece I wanted to mention, that I just want to put it out there that, there's also some students, like you're saying, that are urban that will go into a rural setting, and that question of like, and it's not a one way or a recipe, but like, what are some things that need to be considered when you have no rural background and you are then placed in a short-term, don't know anybody, rural setting where everybody knows each other, but nobody knows you. No one's going to get to know you because you're only there very, very temporarily, and there's a whole different dynamic of what might happen there. So I think there is so much to unpack, but I think for allowing the students that idea of just exploring it and hearing, I think we should really consider doing this as a cross-campus thing when we finally, I'd love to do it even when we do it with UMed, but we're not quite there yet. But I think for us in particular, for our go-by campuses, it's a really important conversation that doesn't happen so often.
Can I jump in? So my 2.1 has to do with the religious faith. And that is, and Christy also, I think that talking about the provider's experience might be another portrait. I really, really, really want to focus on the patient's experience for this. But I think that it's important, maybe in the next phase, or as a separate portrait, to then have sort of a provider arm for all the issues that providers, have with these same themes, right? So, yeah. Want to put that out there, and get your feedback on that. And then the other question I have is, how how do people feel about the scholarly readings? Are they helpful? Should we just, when we roll this out, should we just be giving the interview? It's so rich, and so much of our conversation has been about the narrative, and that's the sort of starting point. But I'm wondering if we could also think about the portrait as more than just the narrative, and whether or not those people are helpful, or if you think we should be looking for others.
Did you want to add to that? Oh, sure. I can answer both. The one thing that I wanted to say earlier, sorry. And I know Carrie still has to be today. Sorry, Carrie. I'm gonna go here next.
I jumped in. I got my medication, and then I have things to say about that too. Just gonna live. I do have a list.
So the one thing that I wanted to talk about earlier was just the setting of the emergency room. I think is really interesting and can be quite a unifying theme between when we want to draw some of the similarities between rural and urban settings too, because ER means access, and if you're uninsured, like there are laws that say if you show up in an emergency room, you have to be treated. But that you could walk into my clinic and I can turn you away if you don't have the right insurance.
You have to be seen. You don't have to be treated.
Oh, okay. So actually, that's a good point, and I think that would be.
That's a really good point.
It's true.
Yeah. So, but there's really interesting history around that in Chicago as well, with like pregnant patients showing up in labor, uninsured, to an emergency room, and they're like, "Oh, you can't pay. Here's an ambulance. Go to county." Like, so very similar type situations, but in a completely different setting. But the unifying thing is like the emergency medicine. So I just think that's an interesting thing to draw upon when, like, say we're doing this with the students and say they're all their experience is urban, but we're trying to get them to think about these things, try to draw some.
This makes me think that one thing you could also do, depending on the group you have or the groups you have, is give students free work to look into different aspects. So, like, have someone come in as an expert on EMTALA, which is the emergency medicine thing, right? Have someone come in as an expert on HIPAA. And by expert, I mean, okay, you go find out the relevant things about this. You go find out the relevant things about this. You go find out how the EMT structure works in this county, or something like that, so that they could become mini experts on different things you wanted to focus on. So that could be interesting.
Great idea.
And the other thing, just to answer your question about should we have them do the scholarly reading, I think it's going to be pretty impossible to get M1 to read it and to understand it, especially if we assume like someone with like a biochemistry background is not used to this kind of stuff. Like, absolutely, I think they should. But I'm wondering if it might be more helpful to, like, you really well done, sort of have the person leading the discussion, the teacher, like, guide them to where you want them to go and have them kind of discover it on their own, and then certainly offer those supplemental readings that are very interested, and to also have, I think those supplemental readings are going to be even more powerful when they're in their clinical clerkships. To think, I don't know, I mean, I'm thinking about this as like phase 1, phase 2, then it would be really helpful for them to start talking about the hidden curriculum and how it relates to performance, things like that. I don't think they're going to get it as an M1 because they haven't been in that situation where they're performing as a med student or watching a performance, at least not in the same way. Yeah.
I think that's important, although then it's not a portrait, because the portrait is not just the narrative. The portrait is that plus what you're calling supplemental is not supplemental.
Right.
At least in the approach. I mean, unless we just want to dump the approach and whatever. But I think at least in the way that
students will show up not being read.
That's not a reason. But they're not going to read. They never read anything anyway. Yeah. So but I guess the question is how we conceptualize the portrait, and then what we give to them for those 10 students who maybe will read it. That will be the most effective. Does that make sense?
As I've been hearing all the different ideas, I've been thinking about how we might want to structure these portraits as units. And what I've really like about what you presented to us is your boiled down points, because the boiled down points, I think, can be understood across disciplines, and so you've made them accessible. So I think that having something similar to that. I also have been thinking more and more as we've gone on that we really should think about having each expert write an introductory piece. So, and I know that kind of like a keywords book, because when you gave us just 3 or 4 concepts, like performance is this, 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 you were able to pull down what was useful to this conversation, and you used it throughout the whole lesson. So I think that was really cool, because you could, so I'm thinking about history, working with Ellen. Like, what is a historical approach? But what if you boiled your discipline down to, you know, like with performance, you have a performer and an audience. Like, you can boil it down to, there's ways to boil it down. And if you want to, you could be some deconstructionist scholar and break that down even further. But let's just say, you know, you're going to have that. So I think that, so the boiled down points of the overall lesson, the boiled down methodological approach, and perhaps a short piece by the expert that could bring in some of the ideas from the readings, like as a little introduction, like if this were an anthology. And I also thought that when you brought up the what you can do exercise, that we might have suggested exercises, depending on who's teaching it, they would say, oh, this, I like this exercise, and these questions, or I like it. And then maybe different ones of us coming from different disciplines could offer certain questions. Because that was what started turning in my mind, Sandy. You, or maybe it was Gretchen, when you guys were asking how you would teach it from your own discipline. Because my head went to, I would do this as improv. And another vocabulary word I would add to your list is given circumstances. Because given circumstances is a performance concept. Is like when you're acting, you can only work with the tools that the playwright gives you, or the set designer gives you, or the costume designer gives you. You have to work with what you have. And that is very transferable to the conversation that we had today. So that might be one additional vocabulary word. But you know, if I were teaching this, I might want to experiment with doing improv games or theater of the press type games, and have the students on their feet. But then somebody else in it that might fail, you know, spectacularly, or somebody else would feel completely uncomfortable doing it as an improv game. So I think that it might be fun, like, oh, hey, theater and performance people, here's a suggested exercise. If you wanted to, you could teach basic rules of improv and have them, since this is about identity, now you heard this person or this person, and have them just play out a few exercises. Anyway, so I just started thinking about the format of how we might want to present these lesson plans based on all the things that we've heard, so that people will actually take them up and use them and not be intimidated if they're not in that particular discipline.
And I think that's really important, and I want to reiterate what I said at the beginning, that I think that anyone who teaches this has to teach it their way, right? And I think that's also modeling what we want as medical providers, which is you provide healthcare in your way. And that is not to say that you don't have given circumstances or a script or a culture that you're responding to, but you cannot, two people will not provide care in the same way. They have to provide it in a way that's authentic to them. So teaching is the same. Like, I can't teach as a sociologist. I just can't. I'm not trained that way. All right, I can teach as anything. But you have to teach in the way that feels realistic to you. Yeah. You had your hand up earlier too. Super quick, and then
Just kind of going off what you said about this portrait is so diverse and there's so many different directions that you can take it. And I almost am kind of seeing this case as like a choose your own adventure case based on the need for the expertise of the person that's presenting it. And so you could use your supplemental reading to focus the student. So give them the transcript to read. And if you're going to focus on, if you want to do the portrait on privacy, then you pick a supplemental that talks about privacy. And talk about performance in the environment, like you put that performance piece in there. If you want to do access to care in rural areas, then you put something in access to care. And so that will kind of focus your discussion a little bit better and make and think the depth of the conversation was useful for the student and give them the background information that they may not have to have those meetings.
So, so I agree. It's unlikely that they're going to do the reading, but I don't think that's not. I don't think that's a reason not to assign it. And I really like this pair of readings because so performance studies is entirely new to me, but as best I can tell, there's a lot of sort of micro-sociology, sort of Goffman-esque sort of phase. Yeah. And the problem with that, of course, is that it's divorced from social structure.
Right.
And the other article here is very much about structural aspects. So I think that analyzing the narrative at the intersection of those two, and especially you discomforted the idea of calling performance-based divorced from structural.
No, I was thinking about what it was. Yeah, good. I'm not uncomfortable.
So,
I can't hurt.
So at any rate, I think that this narrative sits very well at the intersection of those two. It's not maybe not the best review paper, but it's good. And it talks about barriers in a very structural way that we want to make sure, because there's a possibility here of looking at performance just sort of inhabiting a professional role, and that's not all of what we're talking about. We're talking about understanding those things, those flows and structures outside of the ER.
So I will say that I struggled, and Sandy knows this, in finding the two readings I wanted, because no two readings did what I wanted them to do. And so I was kind of going back and forth with, like, is it short enough? Is it jargon free? Does it get at kind of what I want? I either wanted to assign no readings or 30, and we had two. So it is really hard to find the things that will do what they want. So, and that's not an excuse. That's just me saying, like, yeah, I agree with everything you're saying. Like, it's hard to find the two readings that will do. And I put one of my own in, which is also weird. So yeah. Oh, Eric wants to talk too. Eric,
I was just going to say, I thought that the pairing that you chose worked really well, but I sensed the challenge that you must have experienced in trying to identify those, because no one article is going to sum up the whole of the person's social reality. And so just as is the case when we write an ethics case studies, in a way we almost have to become so focused. I think we bump up against the same challenge even within the portraits, because no even small handful of articles can really sum up all of the social realities that could be playing into that experience at that moment. So.
And if I could just throw something in here, one thing that I found that is quite successful in teaching, especially students that you don't think are going to do the reading, is to give them some authority, like you are a co-facilitator, you are an expert. Just this year, our students, I teach a class that has facilitators, so I'm a course director, and then I give the facilitators information and give them talking points and lesson plans, and then they get to do what they want with it, but I give them a kind of like, everybody should do with these, like, the 4 things I told you at the end, like, everybody should leave knowing those 4 things. I don't care how you get there, right? But the students this year said, can we see those lesson plans? And I was like, sure. I hadn't thought about that, but they wanted that. They wanted to know. I thought that was actually really smart of them to say, let me see what you're telling the facilitators so that we can also facilitate the discussion. The only drawback to that is some students will want to talk about what they want to talk about. And so you sometimes have to further interrogate where they're like, well, I wouldn't have talked about that. I would have talked about race. And then you say, okay, race is really important. Why is it you want to talk about that? And how do we also cover the other things to cover? So not going like, what do you guys want to talk about? But drawing them in at every level and saying, like, even these questions, because I gave you guys a ton of questions that we didn't even go over, okay, like, which ones do you want to talk about? Why don't you want to talk about that one? Because sometimes they want to talk about the thing they know about or the thing they're interested in, and they don't want to talk about the thing they don't know about, the thing that's going to upset their colleagues, right? Like, they don't want to touch on anything that's going to make them take a point of view that will upset their colleagues. Like, so in kind of getting at, that's part of what a facilitator or faculty member can do is, so you all want to talk about X, Y, and Z. Nobody wanted to talk about A, B, and C, but those are important too. What's up there? Like, why didn't you want to go there? But I think transparency, like I've become to believe more and more, like just give it all to them. And whether they read it or not, your job is to kind of guide them through and get to like the takeaways, which I always do. I always start with objectives and then I either repeat the objectives or do takeaways. And I learned that from other faculty at my medical school who were like, it seems like you're repeating yourself, but it's super helpful to just say, we're going to learn this. Did you learn this? Right? And then if you didn't, you need to tell me you didn't learn that. So, yeah. Shay.
So despite all of my various job titles, my background is actually in education, and I think there's a aspect that a lot of people have touched on that draws, or where we could introduce more basic educational pedagogy and philosophy of the way we generally do education is you give kind of the basic, what we think of as facts, and then you expect people to analyze and critique and use them, but we never really give the middle steps of like, how do we synthesize this? How do we apply these to different situations? And I think that could be a very important part of the additional portraits, especially if we look at it from a provider point of view. It's not just, did you learn this information and can you think of 3 ways to apply this? But when you become a doctor, what will you remember from this about how to do additional research so that you can find out more about your patients without relying on them, but how do you do your own research and how do you use that research to better the care that you're providing? And it would be really hard to find already published, but there was a portrait of a provider who does that work and especially does the emotional work involved of saying, like, I didn't know this about this particular population, and here's what I did to find it out, and here's how I use that information to structure how I interact with people when I'm providing care, and how I use that to interact with other providers, and how I use that to impact the system, which is a whole lot to ask for, but also could potentially be something that people in this room can create because you're going through that process.
So there are a couple terms like methodology and critical thinking that I'm actually not embarrassed to say it took me a long time to figure out what people meant, right? Because in education we often just kind of say like, well, my methodology is this, and I would say I was 3 good years into grad school before I understood what methodology was, because no one ever told me it's the way you approach something. They just kept saying methodology. And so I had to like hear it over and over again in context before this very basic idea of, oh, it's the way you approach something, and it's not set in stone, and the whole idea of bringing up methodology means there are different ways to approach, and that's okay. That took me years. And so I think you're absolutely right that you can shortcut that by asking questions like, what will you remember? What will you apply? The other, like critical thinking, same thing. I was like, I'm a critical thinker, but I don't know what that means until I finally realized it means I am questioning the very basic assumptions here, right? Like I'm willing to question everything, and that's okay. And I think that's very hard for anybody, but especially for our students who have been told, here are the answers. We need you to know facts, and then to say to them, maybe those facts are wrong, and that's okay to question that. I think we really need to pay attention to, like, I try not to even use the word like methodology and try to say like, get to what the point of it is, which is, how is this being approached, and do you have questions about that approach? So I think that's really important. I saw a bunch of hands. Who's got the closest microphone? Christy or Joanna? Actually, I want to, or Allie. Something I don't want to
forget that you brought up in the beginning, and but you said something like, I wouldn't introduce this to a group that I'm just starting to teach. And so I'm wondering, in the context of this, it's most likely going to be people, if it's in their first and second year, they don't know each other that well yet. And so at some point, I want to get your thoughts about why you said that. And like in our approach, our UN students are going to know each other a little bit better. But in most situations, and we'll put this on the web, it's probably, I don't know, if a small medical school in a rural area, like different, but I'm just wondering what your mindset is that we might think about if we had to adjust anything based on that content.
Sure. And one of the reasons I said that is because I am always very conscious conscious that I am not an MD. And that automatically makes me a lesser authority. And I don't say that as like, for me, I have just come to realize that, right? So I have to build trust with my students that I am going to teach them something that is worth their time, right? And that has gotten better over the years as I have become a known quantity. But still, what I teach, I am not an MD, and I am teaching arts and humanities, and that I have to build that trust. So I think that may be a different process for someone who can say, and I am an internist, and I am a pediatrician, I am a physician. That the trust is already there. I think it also makes a difference if your students know each other and they know the course or the unit that it's being put in. So that may have been over individualized, that I'm just always aware that I have to start with, okay, you're gonna have to trust me that this is gonna be useful. And I would love to know like how to do that better. Because for me, that has always taken time, just because of who I am and what my training is. That I do not start with a position of trust. So.
They'd all love to do theater games then, right off the bat.
I have tried that.
I only do theater games with in an elective course now with fourth years, mostly some lower courses, but that they have said, I come to you to your course because I trust you. But I have learned where the boundaries are. If it's required an elective, it's a really big thing too. People who have to be there versus people who are willing to be there. There's often a big change, and I've learned to respect that. And you can do them, but it's going to look very different. So, and don't underestimate how one person who really doesn't want to do it can end the experience for everyone. So, I do theater games, but I don't do them with first or second years anymore, unless we're in an elective setting where they didn't have to come.
Gretchen, when I'm thinking about the students and what they'll read and what they'll engage with, they really like to see videos as opposed to read the script. Tell me what your thoughts are in terms of making that a video that they would view as opposed to reading the actual interview.
That could be interesting. I mean, I think we did audio interviews with all of these folks in part because we could anonymize, right? So audio allows you to take names off, and for the providers in particular, that was really important, that they could be in some way anonymized. I think Isla is fine being public, and I might approach her with that idea. I think it would probably, my experience has been that when you put a video camera on someone, it changes their storytelling, and it would be interesting.
The audio.
Right? We could play the audio too. But it would be interesting to see what she would do with it on a video. But the audio I played a little bit last time, and I personally, I love to listen. When I work with oral histories in general, I don't work from the transcript, I work from the audio, because there's information to me in there. But that's because I'm a performance person, and I want to hear their voice, and I want to hear and I had them do, I think I talked about this last time, but I had a verbatim translation done, which means they leave in all the ums and uhs, and that costs more. Because what most people want is non-verbatim, they want it cleaned up. And if you give someone their transcript, I've learned this too, because I did interviews for the National Cancer Institute. So I was interviewing all their directors and stuff. They cleaned the heck out of there. They're like, I don't say that much, and I'm like, you do. But they don't want their transcript to look like that. So I think the audio is very useful. And I agree, students do like video. This could maybe even be presented as like a podcast kind of thing.
Yeah. Well,
yeah.
Like, could that be like this, like the audio? Yeah, like to have.
So that could be the option.
Like, yeah, because you could do last time.
You could give the reading, but also have the audio played.
That would actually improve accessibility too.
Exactly. Maybe a good option.
And to say like either listen to the audio or read the transcript or both.
Or do that. Like,
That's true. You could also assign, some people say like who volunteers to read, who volunteers to listen.
Do you want to comment on this conversation, and then I'll
and then we'll go to Allie.
Yeah, I think that's an excellent idea, because I think that too, it would be a really good point to point out what the different experiences of hearing the story are and what differences those make in how the students experience it. So for my narrative medicine elective, I had a number of readings, and I was just surprised one time because the student said I'd listen to the audiobook. And they talk, so basically, and his breath becomes air, and he passes away. So the audio changes from a male voice to a female voice, very abruptly. Right. And so, but to me, it was kind of like, well, yeah, I turned the page, and it was
but like for her, it was an incredibly jarring experience to have the story end so abruptly. And so it brought so much more to our classroom discussion when she was like, oh, I didn't read it, I did the audio, and these are the experiences I had hearing that story. So I think that actually would be a powerful way to do it. And then sort of you can come back to a lot of those questions, like how do we hear performance, how do we process? But, okay. I mean,
Yeah, and then Alex said maybe.
This just reminds me of something that Carrie said about the info sheet or like a one-pager that about methodology. We had talked, Gretchen and Michael and Joanna, about whether or not each expert should have like a 5-minute video of themselves, just to orient. Both the facilitator, but also the students. And some people are for it, some people are not, whatever. I think we're just gonna make it optional to, if the expert wants to do that or not. But that's another way to get at, like Ellen felt that she could just talk about Morocco rather than us, 70 Morocco, which I think is a better approach for this particular project. The other thing I want to get back to what Matthew was saying is that I'd like this portrait to really focus on the structural stuff, because I mean, these students are getting a lot of the individual role modeling, professionalism, individual bias stuff already in the curriculum. But what they're not getting is the structural issues. And so the portrait approach is supposed to really focus on that. So, I mean, every facilitator or every teacher is going to do whatever they want in the end, and we don't have control over that. And they should be, responsive to their students. But I think the goal of it is to help students understand and be aware of the structure, the broad issues.
I think that there's a lot of structure in how the structure is out in the content. So you're now okay, this is something. How does that play out? How does structure? How someone? Yeah, so there it is.
Do we repeat?
Yeah, do you want to just repeat it? We're definitely going down.
The new curriculum, I think, talks about structure more than it has before, but it doesn't play out how the structure contextualizes into people's lives. And I think this does that.
Yeah, I actually want to go back to what she was saying about the sort of synthesis piece. And I think what was so useful is before you got to the main point, you did this sort of like keyword kind of synthesis of us. And I think that is actually a really crucial step in helping us collectively synthesize the conversation we've been having. So that perhaps that's something you can put actually into the teaching guide in a way of like, it doesn't have to be that exercise. Like what are some of the key words themselves, but some sort of exercise that gets to the same type of synthesis before you boil it down would be a useful process.
Can you give an example?
Yeah, well, I'm just thinking, we did it verbally, but I often do it in the classroom where I say like, okay, we've talked for 45 minutes about all of these different things. Now give me the words that we use. And I put them on the board. And then sometimes we'll like actually draw lines connecting them. Like, how does this connect to this and connect to this? And
got it. Yeah. And one of the things I thought about was I didn't know what the setup would be, but like using the whiteboard and having like, or overlaying maps over each other. That's a really cool exercise too. Yeah. Or like, how do these connect? Or like, put all the words up. Where would you put them on? Like, there are lots of visual things you can do that help visual learners, if that's actually a thing, like remember stuff, right? Yeah. So some people might not remember everything, but they might remember, oh, I drew my map this way and this, or I remember this list of words. Yeah. I really, I struggle teaching anything in an hour and a half because I want to make, and part of it is like building authority and trust, but also building community and consensus. I want to know who I'm talking to, and I want to know where they're coming from, because I have also learned that makes a big difference in whether they actually receive the teaching. right? Is I am constantly, and Sandy and Michael commented on this last time, that I'm constantly like adjusting to where people are, because if you are talking over, above, outside of their experience, it doesn't land. And so knowing who you're talking to is super important. So that's just me again, like that's where my teaching comes from, is I can't teach at people, I need to know where they are. So. Sure, did you have one more?
Well, I was just wondering, you're talking about where people are from. I was just wondering if it would be helpful to have students say where they're from at the beginning of the activity whenever, well, so I guess it depends. If you're meeting the group for the first time, I think it would be helpful to say, like, I'm Emery, I grew up in Indianapolis, like a fairly urban setting. You know, I lived in Oak Ridge, Tennessee for 2 years when I was 5. Like, that might then help, one, the instructor sort of understand where people are coming from, but then the students might actually learn something about each other too that they had assumed differently. Like, they might have assumed the person sitting next to them grew up in Chicago their whole life, but really they were from some rural place, you know, something like that. So I think that might be like an activity to do at the very, very beginning.
So one of the exercises we offer our facilitators, some of them do it, some of them don't, is certainly you go around and say everybody's names, or you have a nameplate until everybody learns everything. But an activity I've used that some of our facilitators, like with the groups they meet with again and again, is they ask a different question each time. Yeah. Right. So like it can be as simple as like, what's your favorite color, or icebreakers, right? But in this case, it could be like where are you from could be very important, or where did you spend your childhood, or I still remember I took a class on Native American history as an undergrad, and the first thing he said was, say your name and what you think of when I say the word Indian, right? And so like everyone went around the room, and I was like, I'm going to be honest. I think of moccasins and beads and like, and I was like, that's what I think of. And he's like, you know, and several other people did too. And he's like, that I wanted that out on the table, that when you think of Indian, you think of this. So you could do something similar, like when I say rural, you think, right? And then everybody offers a word. And that's also, but that's also like it can be a real litmus test for like how they work with each other, what they're willing to say to each other, because some people might not say the thing they're actually thinking, some people might. Yeah, I just, all of this is so dependent on given circumstances who you have in the room and what's going on. So I guess I will sum up the same way that I started, which is to say that I think anyone who takes on this portrait is going to have to adjust it for what they want it to be, and that I've written it or revised it twice and presented it twice now, and I think it needs like maybe 5 or 10 or 20 more times before it's right? Because like you never, like it takes so long. Every time I teach this or think about this, I'm like, and that. So I would say that just to say like, it's still open, right? Like I think Isla has given this, like this is an incredible gift. And when she gave it for our project, and then when I said, can I take it for this NEH thing? And she was like, absolutely, this is something that should be talked about. I felt like I was given this incredible gift. And I think it's still open to whatever you need it to give you. So that's what I would say. And Erica wants to say something. So I'm concluding. I'll let Erica say the last thing.
Sorry, it's always better after the conclusion. but I just thought I would comment on the suggestion of asking everybody to say where they're from. Yeah, but before I came out to Rockford, I worked in Chicago, mostly in the inner city, for about 6 years. And when I first started, I would often ask our medical residents, oh, so where are you from? And I found that rather frequently, the response I would get is Miami. And I had this sense that they weren't really from Miami, but it happened, a handful of times, and it prompted me to reflect, why is it that you perhaps are not really telling me where they grew up or where they spent the majority of their life, and so I suspect, although it's never really been confirmed, that perhaps for some people there may be a bit of reservation because of the potential stigma that could be associated with growing up or being from a place that's considered less desirable or that has undesirable characteristics. So I just think we might want to be a little bit sensitive to that reality, that not everybody will be interested in sharing those personal details.
Well, and maybe certainly some people, you could always offer the chance to pass. I actually had students pass every time that I used that question. Like I'd say, what's your favorite color? And someone would say pass. And I'm like, all right, they have a reason. Like they don't want to say, but that always needs to be an option. And also, like, you know, whatever they say, you take that as what they offer to you. But you're absolutely right that there may be stigma attached to even saying, I am from, you know, wherever this, like my grandmother is from Sandy Mush, right? Like that's, like that might not be something that someone wants to say is I'm from Sandy Mush. That's the name of the town, Sandy Mush. It's not a hipster, like hippie organic gardening place, but you know, that was not a place that you wanted to say you were from because it was a really, really poor colony.
So I think, you know, just a second on that, is that when asking that question, it's better to ask, you know, I ask urban suburbs, rural, kind of generalized geographic locations, and then after that, where did you grow up? You know, and then in that way, it takes that question, where are you from? Because I don't, you know, usually, me as a, you know, Puerto Rican, this, you know, makes me feel like I don't belong here, so no one wants to answer that question. Right. So it's better, where did you grow up? You know, and where did your family, you know, grew up? And that actually leads to that conversation and takes that defensiveness of the where are you from question.
Thank you both for that.
Thank you everyone. It's 5 for a wonderful discussion. Thank you, sorry. And for a wonderful